today we want to talk about a scheme that we've established with GMMHT, Greater Manchester Mental Health Trust, which is a mental health step-down provision. It's a scheme based in Levenshulme in Manchester. One of the brilliant things about being a national provider is we have a lot of property across the country that isn't necessarily always in use. And we had been approached actually by Shirley, this is Shirley Wheeler, who's the Senior Operations Manager at the Trust, about a similar scheme that we provided in Blackpool, and Shirley and colleagues came to visit that, and that's where the idea of setting up something similar in Manchester to improve bed flow and help the Trust relieve their out-of-area placements pressure. So I'm also joined by Alex Milburn Hughes. Alex is our registered manager at the service. He leads and manages the team at Beech Range. We have been open just 11 months, and part of what we're doing today is talking about the evaluation that the Trust have undertaken at the 7-month point. So we're going to do this hopefully as a kind of in-conversation style rather than formal presentations. So we'll see how that works. I'm going to start by going over to Shirley. And my first question to Shirley is very simple. It's about the why. So why for the Trust was it important to set Beech Range up?
Okay. Hi. Excuse me, I'm a little bit hoarse today. I suppose the Trust was experiencing similar challenges to lots of other trusts around the country in terms of pressure on our acute beds. And the pressure was being driven by people who didn't necessarily need to be in an acute bed, but were delayed or were medically optimised, and it wasn't clear where the next step was for them. We looked at our data, and we also identified that we'd got quite a number of service users who'd been on the wards for over 50 days. And this pressure was impacting on the numbers of out-of-area placements that the Trust was having to utilise. This was particularly apparent in our Manchester services. A deep dive that the Trust carried out indicated that approximately 40% of service users didn't need that level of acute care at the time. There's also lots of evidence, both from service user feedback and from national evidence, that actually once you've had that period of acute care, that actually it's detrimental in terms of your longer term progress and recovery if you remain on an acute ward. It's also highly restrictive in terms of your living conditions. So we started to explore, as part of our GM 10-point plan, what other options there might be to address this challenge. One of the options the Trust did was actually to develop a housing and mental health strategy. That's taken us quite a few months, and we've just actually launched it now. But as part of that exploration, we looked at Home Group, and in particular the service in Blackpool, which was providing step down. We really liked that service because it had actually been formally evaluated by Birmingham University. So the evidence was there that this could work.
And I suppose going on from that, we then discussed in some detail, actually, didn't we, about how we would set the service up?
Yeah, I mean, we liked Home Group, we liked the strategy around innovation, around step down and step up services, but also we liked their values as well. We did a business case, and our execs supported that. The business case was funded through income that had been allocated to the Trust as part of the OPES pressure.
And I think, so from Home Group's point of view, to be able to respond to that, and it being a slightly different world for us, was about how quick could we get a property that was fit for that service, And again, how we could get approval to do something that was slightly different. We were delighted, I'll be honest, to have a different funding stream and to be able to work with the NHS and be funded, but to deliver a good service back. So I think in all, which is pretty good in housing terms, it took us about 3 months to turn a scheme that was effectively mothballed into 8 self-contained rooms with some shared space and a kitchen and so on in a nice part of Levenshulme where it felt it's very much within the community. We invested 40,000 in doing that refurbishment, and that's part of what we do need to get back through the contract over a period of time, and hope that we continue to operate it. What I'd say to anyone that's from another trust, we do have schemes all over the country and would be very happy, based on the evaluation, the interim evaluation so far, of doing that elsewhere. And that's part of what today is about. It's about sharing it, but also saying there are options that will create value for money for you around doing step down. So I think, Shirley, we were going to talk next a bit about the pilot. So it's probably worth saying now that the pilot is an interim one. It's at the 7-month point.
Yeah.
And some of the objectives in that and what we found.
Okay. I mean, the main objectives for the scheme for us was obviously about addressing the numbers of delays on our acute wards, to create some and improve the flow of service users through our acute care pathway, to reduce the length of stays, to improve, hopefully, service user satisfaction. And obviously the kind of primary reason was around reducing the numbers of out-of-area placements and avoiding some costs to the system. We also wanted to increase the housing-related support for some service users. Obviously our nurses on the wards were doing their best to try and access accommodation and housing related support, but that's not their area of expertise. So they were the main objectives, really, that we wanted to achieve.
It's about trusting the experts. And I know this sounds very obvious, but the partnership between health and housing is because we do have different expertise, but both benefit. So one example I often use, and it was particularly in our first step down, but still happening now, is that we understand how to work the housing system and how to get people. So some of the people on the wards actually had nowhere to go to anyway post-discharge. So we're able to really quickly get them on the housing list, talk to other providers, do referrals into supported housing. That's what we do every day. So that's the partnership that I think is really important for health to be able to access. Otherwise we can seem a bit of a closed shop from your perspective as how you use housing.
And it's one of the reasons the Trust has developed a housing and mental health strategy, and recognising that actually these are solutions to some of the challenges that both the NHS and the Trust are facing.
Is it worth, Shirley, shall we share some of the numbers at this point about, from a kind of financial point of view, what some of the savings have been? And
there's probably a bit more to say really about the scheme as a whole. I think it opened at the end of July, at the beginning of August. As has already been said, it provides 8 beds. It's a short stay step down of up to 12 weeks. And it provided an alternative to the ward and a much less restrictive environment for service users who were in recovery. The criteria for referral were for service users who no longer needed a bed but were not quite ready to be discharged home. Service users who had maybe been on our wards for quite a significant amount of time and needed a much greater transition back to the community. And for service users who were ready for discharge but for various reasons, funding, accommodation, the care package wasn't in place for them. And then obviously we've got services in the city, and we had service users who were homeless, and actually in order to address their needs, that took some time in terms of accessing a home and also accessing the right level of support.
Right.
Because it was the first time the Trust had ever done anything like this, we'd never commissioned a housing provider previously, and we were using this income that was identified to pay for out of area placements. So there was some anxiety, particularly from our Director of Finance, that if this didn't work, we could end up with additional costs, which was why we actually agreed to formally evaluate the project, as well as putting in the normal mechanisms, contract monitoring, performance reports, etc., etc. So we've evaluated it 7 months, and the service will have been open 12 months at the end of July, and there is a plan to do a full evaluation at that point. I suppose it's fair to say with any new service, and particularly something like this that we hadn't done before, it did take some time to embed this model, and also to get staff to understand its role and function. So to start off with, referral rates were a bit slow, and actually we didn't achieve the level of occupancy in that first 7 months that we would expect. We had set a very high target, that was 90%, and we didn't achieve that. What we did achieve, though, was that we admitted 24 service users. 16 of them were discharged in that first 7 months. 12 successfully, so I think 9 went to supported housing and 4 went back home. 4 could be categorised as unsuccessful, 2 ended up back in hospital, and 2 left the project of their own accord. The majority of people actually only stayed 8 weeks, and I think that was a concern for us, that actually that we didn't replicate what was happening on the wards, so that we moved people, but actually then we were stuck with trying to move them on at that point. But actually the majority stayed for only 8 weeks, which was really positive.
Shall I just say something about that? Something that is in supported housing's DNA in a way is that from the day you move in, we're talking about your next move. Because we are not setting up permanent homes for people, and so they've made that first step, and you have to sort of keep that momentum going, and Alex will tell us a bit about that, but it was really important to us, and we felt all along that we would be able to beat 12 weeks, because if you've got the right tools and have the right discussions and all your focus is on that, then you can move people quicker. So I think it's been a good result, because that gives more capacity for more people.
Yeah, and obviously we're concerned about the costs. In terms of our business case, we had the costs of an independent sector bed at $550 a night, an NHS bed at $350 a night, and the cost of a Beech Range bed was embarrassingly $116. So really significant differences there. And obviously annually that was something like 1.5 million for independent sector, 1 million for an NHS, and 350 for Beech Range. So we were confident that we could make some savings, even despite the lower occupancy. And taking into account the running costs of providing Beech Range, that did save the Trust on its own beds $28,000. But actually on an independent sector bed in that 7-month period, taking into account all the costs, it saved $190,000. But actually, in terms of total cost of avoidance, there's potentially £500,000 there. So that was really positive. But I mean, the biggest impact for us was about improving the flow. So one of the main objectives was about reducing the numbers of out-of-area placements. And at the time that Beech Range came on stream, we actually were experiencing a real surge in demand for beds. But Beech Range was just one of the measures that the Trust was taking to try and address this kind of pressure in the system. And in particular, that included the development and setting up of a patient flow and bed management team. But we also added some extra inpatient beds into the system as well. So Beech Range played a part in all that the Trust was doing. But actually, it did increase the capacity for us. I think they took one service user direct from an out-of-area placement, 18 service users off our acute wards, and 5 service users from our rehab beds, which then created some capacity within the wider system.
And just on, so I made a quip about us being cheap, but the truth behind that is that we invested in the pilot and the partnership with the Trust, and we had to be realistic. I know that about what we could charge for the Trust to be able to release the money and take their own risk about doing something they hadn't done before. And I just think that's about being a good partner. We wouldn't necessarily always stay at that price, but to start things and demonstrate their worth, sometimes that's what you have to do. If anyone's got a question on that side of it, we take that now, and then I want to just go to Alex and talk a little bit about the service direct. So any question on the setup costs, what Shirley talked about? Put your hand up now.
Hi, I just wondered if you could give some general context about what your housing is like. So, the flow, I'm from Hackney, we have a massive housing issue, and I can just imagine that there wouldn't be anywhere to flow into.
So I'll just say a couple of things from a home group perspective. One is we have capital to invest in new build. It's a big piece for us and for acquisition. So we work very closely with our regulator, Homes England, and are a strategic partner with Homes England, which means we get investment to build or acquire, or in some circumstances refurb. So in each area, I don't know exactly what we've got in each area, but that's why we have the conversations with any trust that is open to that. And there are lots of different options around how we can do it. But I think the thing to remember is we do have capital to invest. That's part of the job. Housing has to build enough homes for our country, and part of that is building homes for people coming out of hospital. It's part of our strategic aim. I don't know if that'll help, so if you want to have a quick chat about that as well, do.
Obviously, we provide mental health services in the city of Manchester, so we also share the concern about, the lack of available housing. And it was an anxiety around Beech Range, because as I said, we didn't want to just recreate what was happening on the wards, that actually, the Beech Range would just get full and we wouldn't have any flow there. But we have moved people on, and I can only put that down to the success of Beech Range and their approach, because there's an awful lot of demand for available housing in Manchester, probably on a similar scale to London.
So I'm going to move to Alex, if that's all right, who's patiently
absolutely.
waited.
Hello.
Alex joined us as our registered manager in October. New to home group, doing a brilliant job.
Thank you.
And so first question really just to ask you is about the impact you feel we've had on customers from your perspective.
Yeah, absolutely. I mean, following the research done by the Trust in the form of the service evaluation, that collated quite a lot of positive customer experiences. I'm blessed with the privilege of seeing the customers on a day-to-day basis. During our assessment process, we always like to invite a patient or a customer, as we refer to them, to the service, so they have an informed choice whether or not they do actually want to come to Beech Range. The wards by nature are quite chaotic, so when they come to Beech Range, the positive comments we've received in terms of the tranquil environment, the homely environment, and the ability to readjust and prepare for reintegration into the community has been nothing but positive. That's also been complemented by significant others from the customers, whether it is care managers, family members, or care coordinators. we're able to transition the customer from ward to Beech Range and then work with them on an individual level and implement a person-centred plan to enable them to achieve the measurable outcomes and move them on to safe and appropriate accommodation when they're ready, and preferably within that 12-week time frame.
Something we did centrally too when we set out on this journey to basically engage better with health and offer housing services that spoke to health agenda was we invested in a central clinical team, and we also have clinicians working out in some of our newer schemes, and I think that just helps to know that you've got other people you can ask as well as the people in the trust.
Absolutely, whether it's our clinical team through our new models of care team within home group, or whether we liaise with the constant presence the trust provides for us in terms of a clinical lead from bed flow management, just to make the process a lot swifter, a lot more effective in terms of identifying the right patients and assessing them in a timely manner and getting them into Beech Range and transitioned into more independent settings into the community.
Brilliant. And is it worth, might be of interest to people, the people we've not been able to accept, is there anything particular about that? Is that learning for the future?
Well, absolutely. Yeah. Well, with more current figures, which I drew up yesterday, in total, since we opened, we've had 62 referrals from all the relevant hospitals in the Manchester area, ranging from Tameside, from Salford to Park House. Out of the 62 referrals, we've accepted 34 of those. We've had to decline 11, based on they fall slightly outside of our referral criteria. But that's also always something we're starting to look at, and if in the future we need to put on a more specialised service to meet the needs of those declined referrals, such as a more clinical setting and a more longer transition period, that's something that we could look to do.
Brilliant. Is it worth actually? I can see it in front of me.
Yeah,
it's
very technical. It's just scribble on a bit like
the latest position. So we've given you the position at the 7-month point, but we're nearly at the 12-month. So where we're at with that?
Yeah, absolutely. 62 referrals in total. 34 were accepted. Out of the 34, we've managed to move on 18 within a 12-week period. And I believe it was 4 have actually exceeded that 12-week period. And we're always assessing everybody on individual circumstances, and we seem to be coming up with barriers which are out of our control. So, for example, if a customer is moving on to a housing provider, it may be that there's specific void works or health and safety requirements that need to be met before that customer can move on. Therefore, that 12-week time frame can be slightly breached.
And the last sort of question around that is just the day-to-day interaction with the trust. How does that work?
Yeah, we've had from the start, I'm confident to say we've had a really good working relationship, whether it's with the senior service managers or whether it's with bed flow or with the ward managers itself. Yeah, it couldn't have gone any better. We're always constantly communicating. It's not just left on my shoulders. My team are confident to communicate with the trust for a variety of different reasons, and the trust have been so supportive in the fact that they have a clinical lead or somebody from bed flow management just to support us with the day-to-day running of the service.
Brilliant. And I think the last point, which you were just talking to me about before, is they've actually had some referrals from patients on the ward themselves.
Yeah, we do. We've got to a stage now where the patients, or customers again as we refer to them, the customers are contacting us direct from the ward. Have you got any beds? What's the referral criteria? How do I get referred? So we liaise with the relevant care coordinator for that individual and try and make the experience as swift as possible.
So do you manage that through a waiting list? Have you got a waiting list?
Yeah, we have a waiting list at present, because we're only 8 beds and a 12-week move-on scheme. So we're constantly getting the referrals in, assessing them and putting them on the waiting list. Since we opened, 17 referrals were withdrawn because we weren't able to provide the bed because it was occupied, and they were withdrawn because they've been discharged from hospital or returned home. So we need more beds. Just need more beds.
Okay, right, that's the pitch for more beds.
Yeah.
Brilliant. I think we'll just open it up for any final questions if people have those.
Thanks, really interesting. David Townsend from Berkshire Healthcare, Chief Operating Officer. We face similar challenges. We're doing many things. We've got bed management. We're working it for 2 years, making some success, but this sounds great. Just wondering around the referral criteria, we know 23% of the people in our beds have got an EUPD diagnosis. Is that part of your referral criteria, or are they excluded?
No, not excluded whatsoever. Everybody's treated on an individual level. We don't discriminate, and we will assess anybody and everybody. In terms of EUPD, I seek further guidance and support from a clinical lead through our new Models of Care team, and I'll also seek support from the Trust and guidance and advice from the ward. My experience from EUPD is, and I don't want to sound judgmental, but as a registered manager, considering the safety and welfare of the current customers who reside there and the staffing members, we have to find that balance. So with an 8-bed facility at present, and I'm always looking to review this, I would personally have 2 individuals with a diagnosis of EUPD just to keep that balance, because you're aware EUPD by nature can be, from my experience, can be quite chaotic and difficult to deal with.
And you talked about your liaison with the wards.
Yes.
Presumably you're also liaising with the community mental health teams as well, are you?
Absolutely, yeah, absolutely. And one of my biggest challenges is just getting Beech Range's presence out there. So it's about me attending the ward managers meeting, attending senior managers meeting, attending events like this, just to get our philosophy and service out there, if that makes sense.
Yeah. Thank you.
I have EUPD, and I'm actually co-chair of the Greater Manchester Personality Disorder Strategy that's been adopted. And one of the things is about staff training. And for me, what you said when you meant, and you sort of hesitated, I think more staff awareness and support for each other, instead of being that single person that has to.
Yes.
Yeah, it's about supporting staff together instead of just one person taking the load of. The
pilot has taught us actually that the different types of training that we need. And you were talking to me about that earlier, about constantly improving our training and looking at other resources that we need to use, basically so we don't have to, so we can accept as many people as possible. It is really important for us to do that.
I was just going to sort of ask a sort of radical type question, which was, do you think in the future, if we just had good crisis houses and then services like yours, we wouldn't need so many old sort of style inpatient beds?
Yes, is the answer to that. And I think the radical bit is how we kind of make it happen faster. It's quite intensive to get those services set up and a lot of work. I'm not just saying this because I'm with Shirley now, but it also does take good individuals to do that, and we've sort of stuck with it. With Francis, actually, who's our contract manager, we keep meeting as a team, and you do need some of that.
I think the trust housing strategy kind of reflects that kind of vision really for the future, and we have to be brave about disinvesting in beds and investing in other models and ways of doing things.